Live from UBC Studios in Kampala. This is Good Morning Uganda Extra.
A very good morning and welcome to Good Morning Uganda Extra. My name is Sharon Chondrisha. Thank you so much for always tuning in and for always keeping it on UBC TV. Yes, we do inspire Uganda. It's the 5th of December 2022. We have a few days to get to the end of the year, but also a few days, 20 days to Christmas, which is one of my favorite holidays of all times. Thank you so much. It's just also 3 minutes past 9 a.m. I hope you're having a lovely day and that whatever you touch is actually going to multiply and be blessed. Today we get to talk about tuberculosis and leprosy. When was the last time you actually heard about this? Now, tuberculosis control in the African region has evolved since the disease was declared a global pandemic or a global emergency by the World Health Organization in 1993. Member states have adopted and implemented successive global and regional strategies and resolutions with demonstrative positive impacts on incidence, prevalence and mortality, albeit with variations across countries. By the end of 2015, the region as a whole met the Millennium Development Goal target of halting and beginning to reverse TB incidence in Uganda, a bid to end TB by 2030. The Ministry of Health has organized the 5th Annual National Tuberculosis Day and Leprosy Stakeholders Conference to account to its stakeholders under the theme Building Resilience and Sustainable Health System for TB and Leprosy in the context of public health emergencies. In studio with me is Mr. Muzamil Bamulova, Community Systems Technical Advisor, Ministry of Health, and Dr. Andrew Ocello, Deputy Project Director for the USAID and Local Partner for Health Services for Tuberculosis. A very good morning once again, and I'll ask them to introduce themselves. Please go ahead.
Thank you, our moderator, and to our listeners out there. I'm Muzamil Bamulova, a Community Systems Technical Advisor, as introduced by my colleague, working with the Ministry of Health. Nice to be here.
Dr. Ocello.
Thank you, and good morning, viewers. My name is Dr. Andrew Ocello, as you have heard, and I'm the Deputy Project Director for the USAID Local Partner for Health Services for TB. We work with the TB program of the Ministry of Health, supporting them in their mandate to oversee TB activities across the country. And I'll be telling you a little more about the project as we go along.
Yes. Now the theme has tuberculosis as well as leprosy. Why the two?
The two diseases are quite related. One is caused by the germ called Mycobacterium tuberculosis. Another one is Mycobacterium leprae. At one time they were called chronic diseases because they would take long to infect and establish themselves. And of course, as you will see, the management is kind of similar. Once you identify the organism in, say, the sputum sample for TB or in the skin snip for somebody with leprosy, then you also have to start thinking about the contacts. Who else had it before? And we then, use that kind of approach to identifying who has TB, who has leprosy. They're kind of quite related in that aspect.
Do we still have leprosy? I know it's a weird question, but that's one of the diseases that you never really hear about.
Yes, we do have leprosy. We know way back in 1994, thereabouts, they had started already talking about its elimination. Actually, it's eradication, but we do certainly have cases in Uganda. In the last program year, 2021, we had 388 cases that were detected. And in the last, yes, and then in 2021-22, we had 477 cases that were identified. And the hotspots in West Nile, in Lango, and also in some areas around Karamoja, and in the west of Uganda, in Toro actually.
Is leprosy the one we're talking about? So in the Bible, leprosy stands out so much, and it ends up taking off people's limbs. And are we still talking about the same disease in 2021? And are those still the effects?
Yes.
Of leprosy?
So it's in its most severe form, it does debilitate. It causes limbs to fall off because it attacks the skin, the nerves, and the mucous membrane, the soft parts of the body. And certainly, eventually causes limbs to fall off because you won't feel, say, your fingers, so you'll injure them or they'll get infected and you won't realize it, and eventually they just drop off. So it's that bad in its worst form. But the good news is that it can be treated and it can be prevented. And prevention really is simple. We can give them a capsule or so of rifampicin. That's one of the drugs that is known also for treating TB. And it's able to prevent, if we are to give it, do it as mass prevention, as a mass prevention measure around people who have leprosy, we know they shall be protected. Those that are at risk for leprosy, we know that we shall protect them from catching it.
Okay. Mr. Bamlova, yes, please.
Actually, I wanted to add up to what Dr. Chela said. Most of the cases that we are registering in Uganda are coming when they are already amputated because of the disease. So leprosy is actually killing and disabling most of our people out there in the community, and they are delaying to come to the facilities, and the effects of coming when you're in a grade 2 disability levels, we can't reverse them back. So the earlier that our community members embrace coming to the facilities early enough is actually the better option.
Why do you think they're coming to the facilities when it's severe?
In most cases, people tend to do self-medication when they have any health issue. So by the time they realize they cannot handle at the community level, to say let me go to the facility, the disease has already progressed to a high level whereby the effects of the disease can't be reversed. Yes.
We're talking about tuberculosis, culosis, and I think for what we've had, it affects is it the lungs? Yes. How is that sort of related to leprosy? Even if you said, the germs and there's like a relationship, I just want to get that clearly.
Well, like we said, the germs are of the same tribe. They're the same, from the same group of mycobacteria. I think we can't relate them in the way you're saying. They're different diseases, but of course their management is quite similar, and even the stigma that they produce around the patient, the fact that there is that isolation associated with the condition, the fact that it causes stigma, as we are saying. There are quite a number of, and it's of long standing. It takes long to establish itself. The treatment also takes a while to complete. But just to again reiterate, these are preventable diseases and they are treatable. And the earlier that the people at risk come to test, to check whether it is there, and it is discovered, it can be treated and they get back to cure.
Has there been an evolution with the disease? For example, in the sense that, I'll give an example on COVID-19, that when we started out, we had one variation of COVID, and then we ended up having like Omicron, and then all this. So has that also happened with tuberculosis?
Yes, we can talk about the multi-drug resistant forms of TB, which result because either people are not taking the drugs appropriately. We find eventually that there are different forms that emerge that tend to resist the common form or the first line of treatment that we use. So indeed, we do for TB. It is clear that if we are careless in finishing our treatment appropriately, we are at risk of getting that more difficult form, which needs treatment for 1 year. And we are lucky that right now it has come to 1 year. Previously it was 2 years, it needed injections, it was full of wrought with side effects, loss of hearing, mental issues, and we know that we can prevent that again by making sure that if we have to be treated for TB, let us complete the treatment appropriately according to instructions of the health worker. So, yeah.
Mr. Mulova, I believe you're in touch with the community most times.
Certainly.
And for example, with Ebola, they told us monkeys at some point, that's where the disease came from, eating monkeys and all that carry that. What about TB? Where does this really stem from?
As initially mentioned, TB is a disease which is communicable. It can move from one person to another. In the context of TB, it is spread through air. When someone who has the TB disease, if he coughs, if he laughs, if he's actually singing, if he's talking, like as I'm talking, he keeps on shedding the TB infection into the space. And any other person who has no TB disease inhales in the infected air, then he's actually contracting the disease. So that is the mode of spread from a person who has it to the person who doesn't have it. So in all, there should be an index case who has the disease.
Where does the index case usually get the disease from? Diarrhea, they'll tell you don't eat uncovered food and all these things. What about TB?
So I think you're bringing up a very key issue. The disease has been spreading from one person to another. Of course, people also talk about the bovine one, the one that is related to cows. Of course, studies have been done to see whether it is, related to the human one. But I think that is still an area of argument. But the point you're bringing is that we can actually, if we work hard to find all the TB that exists within the human being, we can actually eliminate it. We can actually eradicate it. And that is what the elimination of the epidemic by 2030 is all about. We are thinking that, and he will be telling you about the work we have been doing in the communities. We stopped waiting for people who are coughing or who are likely to have TB to come to the health facility. We now go out to them. And that is helping us to find the missing cases, those people who are harboring it and continue spreading it. We know that if you have TB and you're not treated in time, within a year, you've spread it to another 15 people. Studies show that. And those 15 people will likewise do the same to many more people. So we do hope that by what we are doing right now and what we shall be talking about in the conference that you talked about shall help us to get to the final index case probably.
Interesting. Now, cough is really associated with so many diseases. And so how does even someone zero down to, I might not have, it might, and stigma, you talked about stigma, which is a thing that is also, when you cough now, it is COVID-19. When you it is something else. TB actually sort of rarely comes out, but we know that this is also happening regardless of all the other diseases that are being out there in the limelight. So isn't it actually worsening the stigma now? So people are more scared to even go for checkups and all because I might end up with COVID-19 isolated and all these other things?
That is true. Cough certainly is a presentation of so many conditions. And again, a point that you're bringing, we saw a slump in the numbers of cases that we could catch of TB during the peak of COVID-19, especially during the first peak, because yes, people felt stigmatized, and of course health workers were also felt unprepared at that time in terms of being protected. to detect, to work towards identifying TB. So we know that with TB, it comes with a number of other symptoms, signs and symptoms. So for TB, we say you should have been coughing for at least 2 weeks or more. You have a fever, you have drenching night sweats, you sweat a lot in the night, and you're having unexplained weight loss. Now, usually that combination will help you to narrow down to a probability that this is TB. And of course, the encouragement again is that you shouldn't be stigmatized, feel stigmatized, rather be keen to seek help, because TB is curable, because TB is preventable even amongst the people within your household. If we find out that what you're coughing is TB, we can quickly check for everyone else in the home and make sure that if they have TB, we treat them as well. If they don't have TB, we give them preventive therapy. So that is an encouragement to the viewers out there.
Mr. Bamlova, in communities, I think a few years back, for all I remember, TB was also associated with HIV and AIDS. When someone actually had TB, they were already scared that, oh my God, I might have contracted HIV AIDS. How have you helped people understand that these are two different diseases, but one, you might get the other because you already have HIV and AIDS, but that doesn't mean that TB equals to HIV and AIDS?
As you've actually mentioned, these two diseases always move hand in hand. For example, in most of the clinics, our people are actually having HIV, but at the same time, you find them having TB, which relates to being a comorbidity. In this case, these diseases always affect your immunity system. As they affect your immunity system, they tend to lower it, so that anything that actually attacks you is able to penetrate and cause a disease in you. Because there are two things, there is infection and disease. You can have the infection, but when you are not actually presenting it out, you become asymptomatic. But at the same time, when you have the disease, you are able even to present the symptoms. So in this case, when one gets HIV, his body immunity is always lowered, and in any exposure to someone who has the TB disease, there are higher chances that you'll actually contract the disease of TB, and therefore you'll actually have the two. But what we need to bring out to the listeners out there is that HIV is different from TB in terms of diagnosis and in terms of management. But the viewer should actually appreciate that it is not bad for you to test for both of them, to rule out one of the other. If you have TB, you can actually have TB without HIV. At the same time, you can have HIV without TB, but there are chances that you can have both at the same time. But the beauty is both of them can be managed at the same time if you actually visit our facilities, which are near us. Yes.
Doctor?
Yes. I'll just add that, like what he's saying, there are comorbidities, and once you have TB, we know that between 35 to 50%, almost half of them can be HIV positive. And therefore, we are actually working hard to protect people who have HIV from getting TB. Currently, we are offering them preventive therapy for tuberculosis.
What's preventive therapy?
We offer some form of some drugs, and currently it is a drug called isoniazid. We give it with vitamin B6, and it is offered for about 6 months to this individual who is HIV positive to prevent him from getting TB. And we know that once you do that over a long time frame, studies have shown between 6 and 9 years they're protected. Now, if we're able to do that for everybody who is HIV positive in the country, and we are also working elsewhere to find all the missing cases, the logic is that we shall reach a point where no one will be at risk. So that is why right now that is actually another campaign that we have undertaken. We know that 6 months can be long, but a lot of work is happening. We actually have some work that is going on to start the provision of preventive therapy that lasts about 3 months. And there's another one that is just for about a month that we eventually shall be also adopting. So that is good news about that relationship between TB and HIV. Yeah.
Leprosy, what are the hotspots for leprosy? I know you hinted, but maybe what are the hotspots of leprosy in Uganda?
The hotspot areas for leprosy in Uganda are basically more in West Nile, more in eastern Uganda, that is the Busoga, and in Karamoja there we have many of them. And the worst bit about it is that these people who are actually coming to the facilities are coming when they have actually progressed to a level 2, which has actually caused issues of disability. But in this very context, after the ministry knowing what is happening out there, we've gone in to initiate interventions that go to the communities in a way of a campaign to do community mobilization, sensitization. We do screen the VHTs, the village health team members who are actually out there. At least we can actually mention to the public that across all the villages of Uganda, in the month of September, we were able to engage at least one VHT per village to be able to be oriented into the screening cascade for both TB and leprosy, so that we are able to pick people from the communities and refer them to the facilities where further diagnosis can be done. So leprosy is scattered almost now, almost within the whole country, but with the hotspots being in those 3 locations.
Why are those the hotspots?
Those areas are hotspots, as we've actually said initially here, that these diseases have been around. And our health-seeking behaviors are not all that so good, in that this one person who has the disease, if he remains in the community, is viable to spread to other areas. For example, as he has mentioned, one TB case alone is able to spread to other 15 people in 1 year. And look at the 1 year, if one is spreading to other 15, and also these other 15 are still within the communities, and they are spreading to the others. So these areas, people didn't actually give priority to signs and symptoms that relates to leprosy to go and seek for medical care so that it can be managed. So they continue to send the disease to the others.
Dr. Ochero?
Yeah, well, I think we also hold it upon ourselves as the health system, as health workers, to keep aware that leprosy is still with us. When WHO started announcing that we're near its elimination, I think the risk was that, you know, we started looking at other priorities. But the reminder now from the CAST TB activities, the community activities we have been doing, what we found on the ground is actually different. There are actually cases that have been with us probably for years. Like we're saying, leprosy takes long to establish itself in the next person, in your contact. So we're finding sometimes it was a judge who was a contact who was showing leprosy once you got somebody with it, meaning that it will take 10, 20 years for the next person to catch it, and that could also explain why we thought there was no leprosy and yet it was seeding itself. So the truth is we still have numbers, and I mentioned those numbers. The previous program year, we got around 388. And then this last program year that was reported, we got 477 cases of leprosy. And that means there are probably other people that we have to keep on looking around for the next few years.
Okay.
Actually, to add on to the statistics, he's giving you a year of getting 400. from this campaign that we did in September. It was actually a campaign of 1 week. In 1 week, we were able to get over 131 leprosy cases across the country. Actually, by going to the communities.
Yeah, that actually adds to that number we are mentioning of the 477.
The problem is actually big out there. We don't need to take it lightly. It is a big one. And we really need to embrace the community interventions to see that people are mobilized, people are sensitized. People should actually change their behaviors to really seek for health services. In most cases, when you have a deviation from the normal life that you are living, get to appreciate that you have a health problem, and therefore you need to go to the facility.
I like that. When you have a deviation from the normal life, yes, that makes very good sense. Now, this is the 5th annual conference.
Yeah.
What has been the progress from the very first one? When did you first have the first one? And then what has been the progress to now, the 5th one? And we only have about, is it 3 years to the end of, to come to 2030? So is it really attained? No, not 20. No, we still have a couple of years, about 7 or something, yes. But is it still attainable for us to actually end tuberculosis and leprosy by that time? Yes, I'll start with Dr.
Yeah, I became aware about these conferences, these annual conferences, from the 3rd one, and the 1st and the 2nd, you know, were still building momentum. But when through USAID we started supporting the National TB Leprosy Program of the Ministry of Health, one thing that we recognized was that there are a lot of stakeholders who are working hard to support TB and leprosy services within the country, but they were kind of disjointed. Everyone was, you know, trying what he thought was best, and so one key thing we recognized was that a conference like this would bring in a measure of, you know, governance, coordination, collaboration, and networking. So since the 3rd conference, we have been working hard to ensure that we review the national TB and leprosy response. So the national TB program, you know, collects data from the work that was done the previous year, gets information about challenges, about needs, and of course comparing them with key targets that are handed down from WHO and now from the UN high-level meeting for TB. And we make sure that we talk with stakeholders, these different stakeholders that are doing a lot of work for TB, to make sure that we're on the same page. We now we have a national strategic plan for TB and leprosy, which guides the discussions, guides the performance reviews, and of course helps us to plan for the year to come. So just like you're saying, in this 5th annual conference, we are going to be reviewing what was achieved over the previous year against the National Strategic Plan, against the targets that were handed down by the UN high-level meeting for TB. That period ends this year. And we are also going to tell them about key achievements related to governance, related to the partnerships that we are building, relating to the community aspects that we have now built into the strategy, into the response. So the work that Mr. Bamlova is doing in the community is a new strategy, a new approach which we have recognized has helped us to continue getting those missing cases of TB, even in the face of public health emergencies like COVID and now like Ebola. So we want to talk more about these issues during that conference. And just to add, the conference shall be hosted by the Minister of Health, Honorable General Thacheng, and the guest of honor is going to be the Right Honorable Prime Minister of Uganda, Robin Anabanja. And of course we shall have other dignitaries from across the board, from WHO, the representative, as well as people from the donor community that support us, USAID, CDC, Department of Defense, QUAM, and others.
Anything else to add?
As a way of topping up to what he has exactly said, the beauty is what we are looking for, we know it. You know what complicates life is to look for something that you don't know. We know that on average, a year, we expect around 90,000 TB cases.
90,000?
Yes, to be found in the community. Wow. And within this, we have started with our community interventions. I can actually mention to our viewers out there that still going to the community within 1 week, we were able to get over and close to 8,000 TB cases in 1 week. So if we are chasing the 90,000 in a year, I'm sure by the close of the next 8 years to get to 2030, we'll have been able to eliminate the community transmissions, and it is out of these community transmissions that probably we may not be able to achieve our 2030 target. So with these community interventions and the high level engagements, we should be able to find resources that will actually make us have sustained interventions at the community level, and we'll be able to hit our target.
Okay.
Yes.
90,000.
Yes.
It's an emergency. Is it an emergency?
Yes, we do consider it. We are one of the high-burdened TB and TB-HIV countries of the globe. But
which number are we?
We're one of the 20 TB-HIV burdened countries and 30 TB burdened countries. So, but the good news is that even in the face of COVID and all these public health emergencies that we're talking of, Uganda has made significant progress, and we are really hopeful that we are going to contain this disease and achieve elimination of the pandemic by 2030. So the thing is, we need collaboration. We need everyone to be a part of this drive, of this campaign to end TB. And so we're encouraging everyone, all of you, to come and be a part of this conference, hear a lot more about TB, and yes, how serious it is, but how much we can actually end it and, you know, focus on other things.
What do you think about people who are like, okay, we're now tired of all the communication and the fear that is being instilled in us because of diseases that have been existing, TB 1993 till now, but now there's TB, then you have to know about Ebola, then you have to know about COVID, then you have to know about all this. So people are, this is too much and it's bad news. What do you tell such people? Well,
I'll start from the point of trying to move our country to a higher economic status. We want to become middle income and of course go on beyond that. And one of the key features that you will notice as countries become more developed is elimination of many of these infectious diseases. And that is what you see across the board. Many of the countries that have achieved middle income status and are moving on at least are able to show that they have eliminated diseases that come out of poverty, come out as a consequence of ignorance, come out as a consequence of poor health-seeking behavior. And I think these are things that we also need to target as we try to strive towards a better status for our people. And it is good that our National Development Plan has kind of figured, is actually looking at it that way. Health is bunched together under the capital development pillar, and that does speak to what we need to do to health as we drive towards improving the economic status of our people.
29 years and yes, please, Wada.
What the viewers out there should appreciate is health is wealth. And these two are complemented by availability of information. in the conference where we are going to share what we've done, the lessons we've actually learned out of them. So people should actually always look at being more informed. Then they should be able to take precise decisions that can actually move them to the next level of either maintaining a healthy status or actually improving their health state. But Dr. Chelo would actually give you more. When you look at one family which will have only one case of TB, the effects that relate to this one case of TB are not basically on the socio-economic component of alone, but the whole family, the whole village in one way or the other is affected, because there are other extra wastes that come in terms of time, in terms of money, in terms of any other social benefits. If probably is a child who is sick, the mother and the father are unable to go to the garden or neither go to work because they have to attend to this sick child. So we don't need to say that people have had a lot. We need to hear more, because some of these are actually re-emerging, because we have mentioned here the two were almost to be declared for elimination, but now they have actually gone to be high. I can actually mention to you that on a daily basis, we lose 30 people to TB on every day. So if 30 people are dying, who are these? These are our relatives, these are our brothers, these are our sisters. So let's embrace the conference. We come and know what has happened and what we've done.
Can TB, yes.
Yeah, you asked a really pertinent question, and we keep on. He's talking about a study that we did that showed that once somebody is ill with TB, he's dipped deeper into poverty. He suffers from catastrophic costs, basically meaning that 20% or more of his income is shifted to handling the illness of the family income, is shifted to handling the illness. And like we say, TB is an impoverishing disease. Leprosy is an impoverishing disease. And they already target people who are vulnerable, who are already vulnerable. So just again to reiterate, the people who tend to be falling sick with TB, the hotspots are in the slums, are in the congregate settings, are in the prisons, are in places where people have less ability to care appropriately for themselves, or to be healthy, or to seek information, or to gain access to the health facility. So we hold it upon ourselves to make sure that the diseases are targeted, particularly these two, because we know they touch the very tender spots in our society. 29
years of fighting tuberculosis, and 2030 is our end game. We want to, at least that's our desire, to end tuberculosis and leprosy. Is that achievable in the next 7 years?
You will not. For TB, we are saying we want to eliminate the epidemic. We want to reach a point where you just have, right now we have about 200 new cases every 100,000 people. That is in a year. But we want to bring it down to probably 10, 20 persons in 100,000, to a level that it's no longer a public health emergency, and at a point where people are very knowledgeable that, if I have a cough, I'm having fevers, let me go out to the health facility and seek help. And there we won't be burdening the health facility. There'll be enough X-ray services, there'll be enough lab facilities to look after those few that keep popping up. And that is what we actually mean by ending the epidemic. We want to bring it to manageable proportions. And yes, it can happen. And what we have been able to achieve right now does show that we are moving in the right direction. The work that Mr. Bamlova is doing in the community is the latest magic bullet that we have allow me to call it that way, and it seems to be bringing us closer to ending the epidemic by 2030.
We're always talking about your work. Please tell us about your work when you're doing in the community.
In terms of, you know, what we need to appreciate is the people who have the diseases are based in the communities. We appreciate the government has set up a number of facilities at parish, sub-county, county, and the district and the national levels. But these are structures with the human resource and equipments in them. So what we've actually thought, even if you put a structure there and people have not been encouraged, have not been mobilized, they will look at that structure like, that is the government's facility, that is an LPHS's facility. They don't come to use the services. So what we've actually done is to go out there to the communities, engage the communities using their own structures. We have done this using the VHTs. You know, a village health team member is a person who is recommended by the community itself, that we have a lot of trust in this person. He can actually handle all our health matters. So we have tried to engage them. Actually, I can tell you that now we have a directory of the VHTs in the different villages of Uganda, which we can actually say, if I'm going probably to Amdat, I can look through the list from Amdat and I say, this person helped us in this village. And therefore, if we see from our system that the more cases are coming from a particular location, we can engage that location. Even as we speak, I can actually inform the viewers that there are some districts which we have identified where the TB disease has actually gone to the level where we are having the drug-resistant TB cases being on a high number than even the drug-susceptible TB case. So we are going to engage the communities. The communities themselves, they will do a self-analysis of the problem. What is it that is the problem? We are having a problem that most of our people are having this problem, either the TB disease for this case. So when they will appreciate it, they will be able to take an action and say, no, we now need to mobilize everyone in this community to go and seek health care. For example, in the community intervention where they are saying it has worked, we have empowered the VHTs, one, to be able to screen people who are presumptive for TB and leprosy. Besides screening them, these people were given, the VHTs were given a sputum mark. A sputum mark is basically which they were supposed to use for obtaining or picking a sample, that is a sputum sample, from the person who has been coughing. This sample is what was brought to the laboratory so that it is actually analyzed, and then we are able to rule out whether this coughing is basically associated with the TB or it could be any other infection in this person. And in the same way, after getting the sample, it is analyzed by the lab. Then the information flows back through the VHT to the very household to inform them, specifically those who had actually been confirmed to have the disease. You are like, so and so, from the analysis which was done on the sample that we took to the facility, it was confirmed that you have TB disease. And then the VHT refers this person to the health facility for initiation onto treatment. So the whole process, we want to create it that it is user-friendly. We don't cause in the component of stigmatization, which we've just mentioned here. Because if I speak to you, I'm like, no, my colleague, you've been coughing for some time. The facility there, headed by Dr. Chelo, offers these services. You will feel free to go there. And that is the approach that we are trying to go in. It is going to be a demand-driven approach whereby the communities will start to demand for the services and then the government will be able to offer the service.
So this is a campaign that we actually launched in the fourth annual stakeholders conference. It was launched by the Minister of Health, and the ministry has gone full force in supporting it. Just recently, the Permanent Secretary, Ministry of Health, and other teams of senior management were part of. They also went out to support, supervise, and see how well the Cast TB campaign, as we call it, was moving. And indeed, it has brought in the numbers. It has helped us to reach people that hitherto were never reached, who could not have come into the health facility. I'll also talk about how we are reaching out to other sectors. We have worked with the Ministry of Works and transport, we have worked with education, we have worked with other sectors to reach out to areas where TB couldn't have been found, using the usual mechanisms that we do. So, for example, and this was through the organization that I work for, the local partner for health services, we worked with NTLP to do outreaches in the bus parks. Ministry of Works helped us to meet the bus associations. We talked to them, they opened up the bus parks for us, and we found TB amongst people who were working out there. In a week of activities, we got 16 cases of TB, for example. During the Uma Showground activities recently, during the Independence Week, we also went and offered screening services. Of course, we do, as he said, for TB and HIV alongside. And we got 6 exhibitors were actually had signs, actually were positive for TB. And this is a wake-up call again. TB is still with us, but we can, out of awareness, out of better health seeking, end that epidemic within us.
Mm-hmm.
Yeah.
In the last few years, this is the 5th annual conference,
Mm-hmm.
but has there been any innovation that has actually sort of helped with the research, or just like showing progress really to the end of, trying to eliminate it by 2030?
Well, quite a number of new strategies have come up, and again, they were adopted in the 3rd annual conference. We launched the National Strategic Plan, which we are currently following, and also the Multi-Sectoral Accountability Framework for TB that is helping us to reach out to other ministries and departments and agencies. But talking about some of the new innovations, they include the utilization of what we call the Gene Expert machine. It's a machine that now, instead of using the microscope that we used to use for looking for TB, it is a more accurate diagnostic tool that helps us to find more cases of the positives. So once you take in sputum, you're more highly likely than not to detect it if it is there. We're also now using the X-ray for screening. So we have digital X-rays which use artificial intelligence. You take the X-ray picture and then feed the image into this program which is in the computer, and it will read it for you and say that this is highly likely to be TB. So all these different equipment or diagnostic tools are helping us actually to become more efficient in capturing TB where it is.
Okay.
Yeah.
Yes.
Actually, to add to what Dr. Chela has said, as another way of innovating, the government through Global Fund secured mobile vans. It's a car. I can say in our ordinary setting, it is self-contained. All the 2 items that Dr. Chela has mentioned, the X-ray and the Gene Expert machines, are actually within that car. It is self-reliant. So these cars are available. They are always moving around. Even I think when you are going to the markets and the show and the bus parks, we're using these cars. They are staged in a location. It is, I can call it as a one-stop center for the health interventions in terms of some checks for TB, even HIV. We do them when it comes to that. So we feel like when the cars are out there, let people embrace them. You just walk there and say, I want to do a TB examination, I want to do an HIV examination, I want to check my blood pressure. They are able to do it there and then, and they give you the results.
How do they check for TB, by the way? What do they usually do? Is it a swab? Is it?
So it's you take a sputum sample.
Oh, okay.
Yes, but then you might have TB that is outside the lungs as well, and so that might require more surgical means to say reach a lymph node or part of an organ that seems to be seeding tuberculosis.
Of late, it seems like vaccination is the way, not way out, but a solution to so many diseases. Ebola, now we have a trial vaccine. COVID-19, we believe we're still in the trial era, even if they're giving us vaccines. TB, are we also...
Remember, you were probably vaccinated at birth.
Yes.
With the BCG vaccine.
Because it's one of the diseases that come on the earth.
Yes, so there has been a vaccine to help control TB. So that is there, but of course a lot of research is going into trying to make a vaccine more effective. And indeed, once we get to that point where we are achieving or controlling the epidemic, now those small or few cases that come in would be more efficiently managed if we had some of those preventative measures. Yeah.
All the research and all the things you're saying seem to allude to the fact that we are preventing and dealing with the already existing cases. Is there anything that is actually going back to the root cause of, I was about to say COVID-19, but of TB, and going back to that first person, or we might even never have the first person, but like going back to the root cause of TB and not sort of dealing with what is already existing?
Yes, the cases that need to be found. We actually, I really appreciate your question. You are wondering whether there is one common source somewhere that can be dealt with.
Yeah.
But I think that one common source is us,
Everyone,
the people,
the
everyone.
community.
Yes. So if we are eager to move out and make sure that what we have, the cough we are having, the night sweats and so on, is not TB, we are in that sense trying to make sure that we are not that missing case. But yes, as health workers and as communities, we need to make sure that somebody who is coughing next to you, it's not TB, encourage them to go out. We need to make sure that we look for those environments where people are and somehow we haven't reached, and you know, root out the TB that is within that environment, get the index case as you mentioned, and make sure that you look for the contacts around them. People who probably, because they're staying in the same household, have you know, contracted it, and they also have to be treated. By doing that, we are controlling the you know, we are stopping that next 15 people that we talked about
Per
year.
Yes, for just one person, one contact. Okay.
Yes.
Now the conference, which dates and where is it going to be, and how can we be a part of it?
Thank you. The conference will be on the 7th and 8th of December. That is a Wednesday and a Thursday. It will be in Munyonyo, and we have about 200 people that have been pre-invited. However, we have been having, since the era of COVID, from the 3rd, we have been making them a blended event. So we have a very interactive, engaging, virtual link to the conference. So we have been sharing flyers out there, and I'm sure through UBC, you'll be helping us also to put them through your social media channels, so that once you click on the link, you'll be registered and you'll be able to attend for the 2 days. People have had a very good experience, and of course through UBC and other channels, you have helped to make it more engaging, more interesting for everyone to participate. So we are all stakeholders. We all have a part to play, and we shall indeed end TB by 2030 if we come together, listen to the performance so far, give in your input and thoughts about what you think can be done better, and be a part of the activity.
Okay, Mr.
To me, what is more interesting about the conference, being an advocate for the communities, is that this time round, the affected individuals themselves, they are the called TB survivors. Those who have ever suffered from the disease are going to attend the conference, which is very key. They will actually share true and live experiences from the TB disease in respect to guiding the nation on what exactly works out. Other than we people sitting in Kampala and we think, no, the vaccines are there, the human resources are there, that isn't enough. And in the same way, the community members, just somebody who is from the community, who is resourceful, they are also going to participate in this conference. So our viewers out there, just feel free, log in at any time. We'll share this on the number of platforms and we'll embrace it.
Okay.
Yes.
Any last remarks?
Well, I want to thank the stakeholders that have played a part in making us go this far as far as TB is concerned. Of course, one of them is the USAID, the United States Agency for International Development, that is sponsoring the activity, and through the local partner for health services that I work for, we are working with Global Fund, we're working with World Health Organization and others to make sure that this conference is a success. And whatever we shall be showcasing, of course, is the National TB Leprosy Program of the Ministry of Health, supported or partnering with all these agencies that I have talked about. So thank you to them, and thank you to the viewer, because I believe you want to be a part of this drive, this campaign. TB is preventable, that is important. TB is curable, and it is curable particularly if you come early, and you, once you're found with TB, you are treated, you take your treatment according to instruction. And I am sure that, like we have told you, we shall be able to eliminate this epidemic by 2030.
Mr. Bamlo, any last remarks?
To me, I just basically encourage the viewers out there that for anything that really touches you and you feel like that is not how you've been, visit the nearest health facility. You'll be able to be helped. Even if the condition may not be managed at that level, the system is flexible. They refer to the next level until you actually reach to a level where they can manage. Seeking behaviors are very key. Let's go to the facilities very early. Thank you. Thank
you so much, Mr. Bamlova. That was Mr. Bamlova, who is the Community Systems Technical Advisor, Ministry of Health, and Dr. Andrew Chero, Deputy Director for the USAID and Local Partner for Health Services, TB, who are some of the people that are actually making sure that this conference takes place. That is USAID, World Health Organization, Global Fund, and Ministry of Health, under the theme of building resilient and sustainable health systems for TB and leprosy in the context of public health emergencies. You just heard it from the doctors themselves. TB is curable. It can be prevented if you follow the doctor's orders. Reach out to the nearest health clinic or health center. Not clinic, health center, in case you feel like that is not the way you usually feel, just like Mr. Bamlova said. Thank you so much for watching. My name is Sharon Chomdisha. Have a lovely, blessed morning. Good morning.
Live from UBC Studios in Kampala, this is Good Morning Uganda Extra.